roughly 80% of people across the country will experience back pain at some point in their lives. Most of us will experience varying degrees, some very acute, some chronic, some kind of nagging soreness over the course of time. There's a lot of different rationales as to why back pain will occur. There's a lot of different reasons as to why you will see pain occurring on a consistent or non-consistent basis. So when we look at pain overall, there are a lot of sources that are going to come into play as to how we address it and how we treat it. And I want to go through some of those today and hopefully give some education as to how you can address your own back pain better, whether it be with PT or with other sources as well. Let's get moving. So first thing, back pain is not dependent on the findings of your X-rays or MRIs. Quoted by a very smart man, if I do say so myself. The biggest thing is that we get these images and we see disc degeneration, we see degenerative joint disease, we see arthritic change, we see herniated discs, bulging discs. A lot of times that's not where the pain is actually stemming from. There's a term or a phrase I utilize a lot: stop chasing pain, meaning we don't necessarily have to go to where the symptoms are. We have to go to where the source is in order to correct the problem. This is not just a back pain based statement or issue. It's broad spectrum for a lot of different things we see here in physical therapy. I do believe that's something where, in order to get to the root cause of problems, you need to go to where the problem is stemming from in the first place. Compression of a joint space is not always where the pain is stemming from. Oftentimes it's more of a muscular source. So we're going to go through a lot of that stuff here today. First off, the anatomy of the spine. So your lumbar spine, which we'll focus on today, is made up of 5 lumbar vertebrae. And then also typically we incorporate your sacrum or your tailbone on top of that. Your sacrum is that triangular bone at the base of the spine. Oftentimes people consider either the coccyx. Technically, the sacrum and the coccyx are 2 separate bones. And your sacrum, over the course of evolution, has basically fused together multiple different vertebrae into what we now consider the sacrum itself. The remainder of the spine is made up of your discs, which are the little gelatinous pieces that basically absorb shock between the vertebrae themselves. Your musculature, your ligaments, your nerve roots exiting the side of the spine. And then your spinal cord, which is that centerpiece, kind of the main pipe in the house, in the sense of where your spigots and your hose lines then come off of. And also your cauda equina, which is this, what it means, horse's tail, where it comes down towards the bottom. Your spinal cord then frays into this different piece of nervous tissue that we call cauda equina at the lower part of the spine. So the vertebra itself, when we look at the main pieces of it, the middle piece you're seeing there in white is your actual intervertebral disc, that cushioning piece. Those things wear down over the course of time. They are gelatinous, fluid-filled pieces with this outer annular ring. I think you can see pretty clearly there. There's this middle section that looks a little bit grayer, and then the surrounding piece, the annulus, is kind of what holds that disc in place. However, over the course of time, the annulus can become fibrotic, it can become torn, and that's where, if you have a herniation, it pokes through the annulus and then back out into that white space, the vertebral foramen, which is where our spinal cord runs straight down and through. So this view right now that you're looking at is looking at the vertebra from top to bottom. The other piece to take note of, I think the part that all of us at some point have either felt or seen, is the spinous process, a little pointy part that pokes right out the back of the spine itself. Also very important to look at is these little pieces. If you look at the part, basically looks like 2 little loops. If I can get my mouse right here, right through here. These are your articular facets. You have 2 pairs, superior, inferior, in each vertebra. These kind of come together and formulate a joint with the vertebra above and below, and open and close to allow for things like extension, flexion, rotation in your spine. A lot of people have heard of facet injections before. This is precisely where they put that injection into, much like if they're doing a joint injection of your knee or of your hip or of your shoulder. They're going into this facet joint to try and reduce down inflammation. I've had this myself personally before, where these have become extremely irritable, inflamed, and it can limit your ability to rotate, to flex, to extend. For me, it was my left side. I couldn't rotate my head to my left. Proper treatment can take care of that very easily when you catch it acutely. The last piece I want to draw attention to is the transverse processes coming off the side here. These are kind of a stabilizing force. A lot of times we're doing mobilizations. We'll utilize these as kind of bracing parts to actually create mobility of the spine. We'll go through that here shortly. The spinal nerves, where they come out and exit the spine, basically exit through the area along the transverse processes and out the foramen. Now, when we talk about compression of the spinal nerve themselves, this is what we're referring to, the point at which the nerves exit the spine and creates compression down through. I want to be very clear on something. Sciatica, as we consider it, is not spinal nerve compression. It is direct compression of the sciatic nerve, where it is formulated from multiple different nerve roots exiting lower down the spine itself. So it's probably the most common condition that we run across in lower back pain when it comes in our door. Many of you that have worked with me before know that from my perspective, it's important to get the right diagnosis down from the get-go, so that way we know exactly how to address it and how to go about the proper treatment methodology. Because if you're having compression, again, don't chase the pain, go to the root. If we're having compression higher up at the spinal column, that's going to differ from if we're having tightness in the glute or in the piriformis that's putting pressure down on the sciatic nerve and creating the pain you're getting. So where we treat is going to dictate a lot based off your symptoms, based off of the compression, but being able to decipher where that's coming from is very, very important. Now, there are 5 primary spinal nerves in lumbar spine: L1, 2, 3, 4, and 5. You also have your 5 sacral nerves, S1, 2, 3, 4, and 5, that come down formally. The lower parts of that, again, oftentimes will be referred more into the base and the foot, and we'll show that here in a second. Common low back conditions we treat: sprains, which would be sprains of the ligaments. This oftentimes gets confused, sprains versus strains. What's the difference? A sprain is a condition in an irritation of the ligament itself. A strain of the muscle belly is more we classify that. Bulging discs, herniated discs, stenosis, narrowing of the spine, degeneration there. Sciatica, we're just talking about. Radiculopathy, which would be considered compression of the radicular portion of the nerve where it exits the spine, which would create then pain, oftentimes referring down the legs. And lastly, compression fractures. Diagnosis of spinal conditions is done in PT primarily through movement analysis. A lot of patients have never had their movement looked at in a lot of cases on the medical level, which to me is the primary way that we should be assessing these sorts of issues. And again, I'll go back to that first quote I put up there, that X-rays and MRIs do not dictate where your pain is coming from. However, the way in which you're moving has tremendous amounts of ways to determine what pressure is being put down through your body, and also what hypercompensations are going on. What areas are weak, what areas are hyperdominant, what muscles are doing things they shouldn't be doing, which ones are underactive, or conversely, which joints are moving well. Basically, we have 3 classifications of how we look at movement: JMD, PED, and SCMD. So joint mobility dysfunction are the joints not gliding themselves. TED, tissue extensibility dysfunction, are the tissues not lengthening enough, too tight, too restricted. Lastly, SCMD, stability motor control dysfunction. How is the body moving, coordinating together? Much like a car, much like an engine, there's a lot of different moving parts that go into making our body run. Is there a sequencing issue going on that is not allowing us to coordinate the movement appropriately? Diagnosis through manual palpation or mobilization. Physically putting your hands on that muscle belly, on the joint, on the ligament, or to see what is irritated, what is creating more pain, what is creating more dysfunction. Strength testing, seeing again where those muscle imbalances are lying. Also, diagnostic imaging. We cannot negate the fact that diagnostic imaging has a huge component into telling us what's going on internally. We can't see through soft tissue. We can't see through the bony structures. So that is certainly something which is very relied upon. However, if we look at the way in which we tend to be referred for treatment, oftentimes we're getting all these scans and images up front. For what purpose? X-rays are obviously meant to be able to show bony degeneration, obviously make sure there's no fractures, things of that nature. However, the common incidence of those things is relatively low, especially with general lower back pain. If you had a substantial slip and fall, if you were coming down the stairs and you fell down 10 stairs, yes, you would want to get an x-ray first in order to make sure that there are no fractures before you begin treatment. But if this is something where you say, hey, I was out in the garden over the weekend and my back was more sore after I was lifting up some topsoil bags or planting some bushes, odds of you having a fracture because of that are extremely low. Now, in the same breath, if you look at the incidence of, degeneration of lumbar segments over the age of 50, it is extremely high, highly likely that you're going to find some degeneration of multiple segments. You're going to find herniated discs or bulging discs. Even in, I'm 38 myself. Even if you look at my age bracket, let's say 35 to 40 years old, the incidence of herniations in my age bracket is roughly about 45 to 50%. Pretty high. You go up to 65 plus, 65, 75, 85, you're going to look in the high 80s to 90 percentiles as far as the incidence of disc degeneration, herniation, bulging, wear and tear through the spinal column. So it's extremely high. Is that where your pain is coming from? Is that the reason why you're having the dysfunction you're having? This is where the combination of the movement analysis, the palpation, the strength assessments tell us a lot more in a lot of cases about really where the root cause of problems are coming from, not just what the structural dysfunction looks like at the moment. Few facts: back pain is a leading cause of missed work. It's also one of the leading causes of disabilities under 45 years old. Costs the American public nearly $50 billion a year to treat back pain. It's one of the number one reasons why we are missed days from work. Over 31 million Americans suffer from back pain at any given point in time. We kind of went through this. This is a study that was done more recently. They were looking at a review of some of the analysis. Back in 2007, the American College of Physicians and the American Pain Society published this clinical guidelines for how we should look at the diagnosis and management of lower back pain. So what they found is clinicians should not routinely obtain imaging or other diagnostic testing in patients with nonspecific lower back pain. Clinicians should perform diagnostic imaging and testing for patients with lower back pain once more severe or progressive neurological deficits are present, or when serious underlying potential side effects or other suspected diagnoses are present. Clinicians should evaluate patients with persistent lower back pain and signs or symptoms of radiculopathy or spinal diagnosis with MRI or CT scan only if the potential candidates for surgery or epidural injection. What does that tell us? How many of us have gone through an MRI or CT scan for a chronic condition that, the result of which we're not really going to do anything differently with as far as, are we going to go get surgery? Surgery should be a last ditch effort more times than not. And that's in a positive way. Surgical procedures that we'll go through here shortly for the lower back, you're not going to change necessarily the net result at the end of the day. It's not like going in and doing an arthroscopic procedure for your knee to clean up a sprained menisci. A lot of times the procedures that are done between fusions, discectomies, laminectomies, you're removing pieces of bone or you're implanting devices to stabilize a segment. It can change a lot of the dynamics of how you tend to move. So going a more conservative route is oftentimes a surgeon's preference first too. But in order to make sure that you're doing the right things, you need to understand the movement mechanics behind that first and foremost. Not every case is able to be handled with just conservative measures. Oftentimes, you do need to go to that surgical level in order to fix the underlying restriction. But it's important to also get to that point first and foremost. We'll talk more about prehab, preoperative rehabilitation as well here in a little bit. Types of pain. Three main types of pain you find in lower back pain. Localized, central to the lower back, typically more involving the central muscles and or ligaments and or joint compression. You'll feel it kind of spread either more right across the lower back, top of the waist, top of the buttocks. These issues more times than not are more central in nature and not as compressive. When we look at referred pain, this is oftentimes confused with radicular pain. The two oftentimes get combined. Referred pain is more specifically talking about pain referred to a different area from a localized source. The best example I always give of this is glute max, medius, and minimus trigger points. So what this is showing in the picture here in the middle where the red stripes are coming down, The blue X's are trigger points through the gluteal muscles, and they are referring pain to these different zones. So oftentimes I get patients that will come on in and say, hey, Kyle, I'm getting pain from my lower back, down my glute, it's wrapping around into my groin and down the side of my thigh. Well, when we look at specific dermatomes of the radicular side, which is the more colorful picture on the right-hand side, that is showing the specific innervation of each nerve root. The dermatome is the sensory component of the nerve root that is allowing you to have sensation in that area. When it becomes dysfunctional, you have a specific pattern. So L2, kind of the top of the thigh, L3, more around the knee joint itself, L4, L5, as you kind of see going down in different zones. Sciatica, back to that, as we hear constantly this term of, I got sciatica. Well, sciatica is very specifically compression of your sciatic nerve. And again, it's extending from the buttocks down the back of the thigh, back of the calf, and oftentimes into the base of the foot. Those overall nerve root compressions are very specific and localized. It doesn't include pain wrapping around the hip, down the side of the thigh. That's not the innervation for those specific nerve roots. So when you look at pain right now as it's sitting for, let's say, the glute max or medius or minimus trigger points, you see how it kind of goes down somewhat into those zones or more down the lateral aspect. Treatment is very different for those, though. If I'm treating somebody with true sciatica, I'm addressing something very specifically related to compression of the sciatic nerve, related to compression of your lower lumbar, S1, S2 nerve root compression. Those issues are very different from, let's say, how to address a trigger point release for a gluteal trigger point. But the pain can be very similar and very much in alignment with what a patient would consider sciatica to be. But again, from our perspective, proper diagnosis, proper movement assessment will lead us down this pathway in order to understand this better. Along with radicular symptoms, you can also get myotomal weakness, motor weakness from an area. So again, dermatomes, sensory component, myotomes, motor component. When we look at sensory component, that's the initial kind of phase of nerve root compression where you tend to see. Think about sleeping on your arm at night and you wake up and it's numb in the morning time, or pins and needles sensation. That's oftentimes the initial kind of sensory component we'll tend to see here. It can also be burning. It can also be just straight pain too. If you get to the point where you're losing motor function, that's a more substantial nerve root compression. That's definitely something to seek treatment for immediately. If you're ever having nerve root compression in the sense of motor loss, bowel and bladder dysfunction, incontinence, things like that, that's definitely time to go get treated immediately. Surgical care, as we were speaking about before, the four main ones you tend to see most commonly: spinal fusion, laminectomy, discectomy, vertebroplasty. So fusion is just what it sounds like. You're fusing the spine together at two or more segments to prevent movement at that segment from occurring. So basically, what you're seeing here is you're seeing a rod screwed into the vertebral column to prevent movement at that segment. Typically, they also do bone grafts to allow for a bony fusion to occur between the segments themselves. This takes time in order to allow for that grafting to set up and actually heal and form that full fusion. That's what fully stabilizes that spinal segment over the course of time. So much like the sacrum itself over the course of time has fused its spinal segments together, our spine can do that as well as we're healing from surgery like this. A laminectomy, on the other hand, when we look at the lamina itself, you could either take out a piece through this lower section here or to open up where the spinal nerve is getting compressed. So if you look at the nerve root getting pinched off by the protrusion here, if you open up this segment, allow the nerve to sit backwards further without having to touch the disc itself. Over here, it's showing the fact they actually remove the entire lamina and open that space up completely. Discectomy, on the other hand, is where you remove the piece of the disc, which is compressing on the nerve root itself. This is considered one of the least invasive spinal procedures to alleviate pressure on a nerve root. The other thing, like we're talking about, it's a common thing that we tend to see as we age, is compression fractures of the spine. Basically, this is where we'll see the vertebral body itself have a fracture within it and either put more compression on an area, become more painful with weight bearing, common osteoporotic, given patients who suffer with osteoporosis commonly. Treatment for this is typically they'll take a injection and basically cement into that zone to stabilize the fracture itself. Very common, very effective procedure. Conservative treatment typically centers around physical therapy, chiropractic care, medication, injection, force bound decompression, things like traction, inversion tables, things of that nature. Obviously, we're going to talk mainly about physical therapy today. We are the specialists in movement assessment. Again, back pain is not dependent on the findings of your X-ray or MRI. It's more dependent upon your movement and how you're able to load and unload. I use a lot of movement assessment, but also a lot of activate to deactivate. How do we activate one given muscle belly to deactivate another? How do we activate one area to unload a different portion of the body? Easiest example I find to understand of this is if I activate my bicep to pull my arm upwards, I naturally have to deactivate my tricep in the back of my arm to allow that motion to occur. Same thing happens with extension of our glute, where if we extend our glute backwards to push ourselves forward or to create a walking cadence, our hip flexor has to naturally deactivate as well. So when we are creating different movement patterns in order to unload the spine, we need to look at that, the activation to deactivation. By looking at the way somebody moves, we can find strengths, weaknesses, limited excessive mobilities, and that's going to play a role into how we treat that patient, how we make sure that condition is moving forward. We've all heard the Newton's law of inertia, and a body in motion wants to remain in motion. Well, an anatomical body, period, wants to remain in motion. Branday's first law of motion. The way in which our body wants to go, the reason why we wake up so stiff in the morning time is our muscles haven't moved in the course of 4 to 8 hours, let's say. They haven't activated. They haven't had a chance to really move. We wake up and I hear this all the time, my joints are stiff. Is it really our joints that are stiff, or is it the fact that our muscles surrounding the joints haven't moved? One thing I teach a lot of my patients is a quick activate to deactivate sequence in the morning time. Go head to toe. You start to do some chin tucks. You start to do some overhead shoulder raises, a little bit of trunk rotation side to side, activating the quads, doing glute squeezes, pelvic tilts, ankle pumps even. Do 3 to 5 to 10 repetitions of each. Take you a minute to 3 minutes tops to go from head to toe, but to actually create movement across the board, allow our bodies start to really wake up in the morning time, to start to get ourselves moving and flowing. I think that'll help us to stop walking like Frankenstein first thing out of bed. When we first get up and all of a sudden we can't move, we feel tight, stiff, restricted. A little bit of simple mobility to activate and wake those muscles back up themselves individually can go a long way to helping ourselves get moving a lot quicker and easier. I think you'll find a lot of times with doing so, you're not feeling the joints as much, you're feeling more the musculature itself. The concept of stop chasing pain we've talked about here as well. Don't go where the pain is occurring. If you're having pain down the thigh that is stemming from the glute, you don't necessarily go to the thigh in order to treat that. You go right to the glute, the source of that pain, work there in order to clear backwards. Now, sometimes you can't have both. You can have a referred source of pain that is also coupled with muscle strain in that same area. So you have to do your due diligence in order to assess and diagnose these things. Make sure you're not having this recurrent carryover where you're only looking at one spot but not the other. So you have to really understand how you're diagnosing these issues. Understanding where pain is coming from is critical to fixing the issue and why it's occurring. This is, again, the root of what we do here in PT. One of the biggest reasons and one of my biggest recommendations why people have lower back pain is glute weakness. We have to strengthen our glutes. Glutes prevent us literally from tipping forward. There are 3 main glute muscles: glute maximus, which is what everything's about as our butt muscle; our glute medius, which is more of our lateral hip muscle on the side; and then sitting underneath there is our gluteus minimus. Coupled within that is that little triangular muscle that you can see there called the piriformis. It runs almost obliquely from the side of the tailbone, the sacrum, right to the side of the hip. Our glutes extend our hip backwards. They help to drive and propel our body forward. So when we walk, we should think about actually pushing backwards with our glute, with our thigh, and with our leg in order to push ourselves forward. What ends up happening lots of times is when we have deactivated glutes, we tend to compensate. Well, where does compensation occur? Well, typically it occurs with our lower back muscles tending to tighten up. So all those long, lean back muscles, so we saw earlier on in one of the other images, that run not just from our hips and our top of our pelvis up to our lower back, but allow us to extend all the way up to our neck, all the way up to our shoulders. So those muscles are very long and lean. Our glutes are very densely compacted. They are much shorter. They are much thicker and denser in most cases. They're meant that way for a reason. So that way we can help propel ourselves back into more upright position. We can keep ourselves held from tipping forward. Um, Most patients actually have difficulty with activation of the glutes. A lot of people are very shocked when they come into treatment and I ask them to contract one glute muscle versus both together. How hard it is to actually create that contraction on a very simple movement pattern, and something which is very, very common to see across all ages and ability levels. It doesn't just happen in the 65 and older populace. It happens in my young athletes. Happens in pediatrics. Happens in your marathoners. It happens to all kinds of people. But this is hands down one of the leading causes of lumbar spine dysfunction. To me, if you look at one area that you should be strengthening hands down, it is hands down your glutes. It has impact on how our foot and ankle mechanics are, has impact into how our knee mechanics are. If you look at knee mechanics, it is dictated far more from our gluteal strength, more so than our quad and hamstring strength. Our glutes have the ability to control the position of the femur going straight down the thigh. So rather than allowing that femur to dive inwards or to bow outwards, changes the entire mechanism how our knee then lands. So strengthening glutes has that impact. Strengthening glutes has the impact to pull ourselves more upright, keep our body from tipping forward. If we're tipping forward, leaning here, we're going to naturally extend our back upwards and upright. That's far more strenuous on ourselves than contracting our glutes to pull us back upright. Strong butt equals strong back. This is something we've proven time and time again, but this is the number one thing that people that come to my clinic with lower back pain, we are hands down looking at these sorts of issues in order to address their lower back pain overall. With physical therapy, it's not just one thing that's going to get you better. It's a multitude of different ways. We use things like joint mobilization, soft tissue massage, trigger point release, corrective exercise, better ergonomics will take a lot of pressure off the back, whether it be sitting for prolonged periods of time at your computer, at your job, sitting in the kitchen doing different things. Improve spinal position overall throughout the course of the day. This is where gluteal strength comes into play. Keeping ourselves in a more upright position because our glutes aren't allowing us to tip forward will help us tremendously as far as not putting more pressure down through those lumbar paraspinals. Think of your lower back muscles like big bungee cords and straps around your spine. If you have already compression of your spine, herniated disc, bulging disc, stenosis, and now all of a sudden you take your spine, you compress it down because your muscles are tight around it, you're going to put that much more compression down through an already irritable area or an area that might be very low key by and large, but all of a sudden you're compressing further, and now you're putting more pressure on your nerve root. Now you're having radiculopathy. Now you're having substantially more back pain centrally and localized. It's basic 101 stuff in the grander scheme of things, but in the same breath is very, very important. Squats, and more squats. A lot of people are afraid to do a squat because they don't understand the mechanics of how it needs to go. But it's one of those things where you definitely do not have to go all the way down for a squat to be effective. But you need to make sure that you're working through your glutes in order to actually create that proper mobility of a squat overall. It's the number one exercise we get the patients on the higher level side, but it's also one of the biggest things people do wrong constantly. Most people push with their thighs, push with their calves, not push with their glutes in order to actually create a squatting mechanism. But again, when you start to change mechanics overall for patients, you notice more substantially how easily these things come into play. That is the end of the slideshow. One of the things that, on the whole, physical therapy has a lot of different ways in order to affect change for patients, both on a local aspect, but also on a much more systemic side. Better mobility will help with your health, it'll help with your balance, it'll help with your ability to be more active, sustain yourselves for longer periods of time, live independently. It's one of the number one things that faces our seniors is, the thought of Can we live independently, or do we need to go into things like assisted living, going to nursing homes? Staying more functional, being able to, take care of yourselves, your loved ones at home. It's very, very important. Um, but this is the baseline of where we start. From my aspect, this is something that, can benefit, almost anybody for that matter. One of the other things I'll leave you guys with is be proactive about your pain. I think far too often we've been conditioned over the course of years to wait on pain to occur and then say, it'll kind of go away on its own. Let me rest. Let me just take a load off. Let me restrict my activity for a day. It turns into 2 days. It turns into a week. It turns into a month. Before you know it, this chronic pain has been cycling. Now we're not moving well. Now we're not moving with any consistency. Now our next step is to go to the doctor, because now it's been going on for a long time. So now we jump into the imaging side. Now we jump into x-rays and MRIs and expensive testing or medications to try and get pain under control. When in reality, if we jump on orthopedic conditions quickly, the odds of it getting better a lot faster are far higher. The need for physical therapy services is something that happens for most people throughout the course of a year. However, if we are proactive about these things, rather than being a 2 or 3 month stint in physical therapy, it might be a 1 or 2 visit episode before you have chronic compensations, before you have substantial pain, which is limiting your function, your ability. I encourage any of my patients, anybody in the community for that matter, to seek out physical therapy services. When you're having dysfunction, when you feel like you're not moving well, when you feel like you are having pain that you can't control naturally. If you're working in the yard over this weekend, and you say, hey, you know what, my back's starting to act up on me. Yes, do some very baseline conservative measures. Try and rest. Get some ice on there, maybe some heat if you prefer that. Do some general mobility exercises, maybe do some glute squeezes or some squats. Try and see if you can help to open up the movement patterns. But if you're not feeling, let's say, 50% better within the first 24 hours initially after you had an injury, had a strain, give us a call. Seek out physical therapy services. Because at the end of the day, we can track down what the root cause of that problem was in the first place. Yes, the strain might have came from the fact that, you're trying to lift that 40-pound bag of topsoil to try and move it to do some planting or to try and fill in some grass this weekend. But at the end of the day, is it something where there's an underlying condition where your glutes aren't activating, you're straining your lower back muscles more to create that movement pattern at that point? Let's get to the root cause of problems. Let's try and get to the point where we're fixing problems before they become bigger issues. That, I think, will be the biggest boon in order to help people get over the hump on back pain and stop this issue from becoming a bigger thing before it takes you out of work, before it takes you out of your activities, before it stops you from going to the gym consistently, before it prevents you from taking care of yourself and your loved ones. I thank all of you for your time today. I thank Christy and Jeanette for inviting me to do this again. Had a lot of fun doing these with all of you guys. I do welcome, if you have any questions or concerns, reach out to me directly. Our phone number, I didn't put this up here, is 203-389-4593. You can also email me directly at kyle@amitypt.com, KYLE@AMITYPT.com. Happy to help you in any way, shape, and form we can. And, hopefully it's been informational for all of you. And hopefully if you guys ever do come across any problems or needs, we're here for you at any point in time.
Thank you, Kyle, for a very wonderful, informative, and interesting presentation.
Thank you.
Last time it was very good. I just want to let everyone know that I will send out the Zoom recording to everyone probably within a week or so. If anybody missed anything, there's a lot of information there so they can go back and rewatch it. Thank everybody for coming and being part of Kyle's presentation.
Thank you, guys.
And thank you again, Kyle.
Anytime. Have a great rest of the day. Enjoy your weekend, everybody.
You too.